Hello, my name is David Burden. I am an IPC counsellor and Professor of Dermatology in the University of Glasgow, UK. And today I'm going to talk about how to diagnose and assess the severity of generalised pustular psoriasis. These are my disclosures. Psoriasis comprises fundamentally either plaque psoriasis or pustular forms, and it is these latter forms that are far rarer and can present greater problems in diagnosis, partly due to lack of familiarity. Similarly, development of highly effective treatments for pustular psoriasis has lagged behind that of plaque psoriasis, and consequently severity scoring systems are less well developed. In the next 15 minutes, I will address both of these areas. The accurate diagnosis of generalised pustular psoriasis rests on a careful assessment of all the clinical and laboratory features, starting with the medical history and including the age at onset, relevant symptoms, particularly pain, burning and pruritus. It is worth asking after a family history of generalised pustular psoriasis and also a personal and family history of plaque psoriasis, as it is known that plaque psoriasis is a risk factor for the development of GPP. It is important to establish the natural history of the condition in this particular individual, whether it's relapsing or persistent, and for those who have flares of the disease, the nature and severity of their previous flares. The history should help to identify potential triggers or exacerbating factors, in particular infection, pregnancy, and also medications, for instance, steroid withdrawal or paradoxical reactions. The entire skin needs to be examined to identify the extent and distribution of the condition, looking primarily for pustules and describing their size and density. It can be helpful to use a dermatoscope looking for pustules in order, particularly when there's a lot of scaling. It's also important to record erythema and edema and scaling and crusting. The mucosa, and particularly the eye and the mouth, need to be looked at, and given that this can be a systemic disease, the temperature and blood pressure should be recorded, and examinations focusing on the respiratory, liver and renal systems. Laboratory investigations are usually required and will include blood work, full blood count looking for neutrophilia, acute phase reactants such as ESR and CRP, urea electrolytes, albumin levels, liver enzymes and calcium. It's often necessary to take cultures from skin and blood looking for secondary infection or alternative diagnoses. Skin histopathology can be supportive with or without immunofluorescence under certain circumstances, and where available, genetic analysis of disease susceptibility genes, particularly IL-36RN, can be supportive. An early influential study of 104 patients with generalised pustular psoriasis, published in 1968 by Baker and Ryan, recognised the clinical heterogeneity of the disease and described 4 subtypes. The first, some bush, characterised by widespread fiery erythema, sheeted pustulation and scarlatiniform peeling, often with systemic features and leukocytosis. Secondly, an annular type, which was lower grade and subacute, with gyrate and annular pustular lesions often with little systemic disturbance. Thirdly, an exanthemetic type, which was often a single short-lived episode following infection or drug exposure. This type I think we would now consider to be acute generalized exanthematous pustulosis, or AGEP. The fourth type, or localized type, described pustulations of restricted areas in and around psoriatic plaques. And this type I think we would now consider to be psoriasis with pustules, a variant of inflammatory plaque psoriasis rather than pustular psoriasis per se. And so of these four types, two remain, the Zumbusch and the annular type, which are illustrated here in two personal cases. On the left, in the acute GPP Zumbusch, you can see the fiery erythema and sheeted pustulation, whereas on the right, the subacute annular GPP with gyrate and annular lesions with pustules at the periphery, often affecting the trunk and proximal limbs. In relation to the differential diagnosis, this table is adapted from a recently published review by Fujita et al., and it highlights the key clinical features that help. I've already described acute GPP and subacute annular GPP. In the first attack, AGEP needs to be considered and can be recognized by small discrete pustules, often on the face and flexures, occurring within a few days of drug exposure and generally resolving within a few weeks of drug discontinuation. There are histopathological points of differentiation, and so a skin biopsy may be helpful. Subcorneal pustular dermatosis and or Snedden-Wilkinson disease and IgA pemphigus need to be considered, particularly in relation to subacute annular GPP. Snedden-Wilkinson disease is recognised by larger flaccid pustules with less erythema than in GPP, and sometimes with fluid levels in the pustules. IgA pemphigus has a different histopathology, and direct immunofluorescence would be positive. The European Rare and Severe Psoriasis Expert Network, or ERASPEN, has published a consensus statement on the phenotypes of pustular psoriasis, and this has been widely adopted. In this classification, generalized pustular psoriasis is defined by the presence of pustules on non-acral skin, and these pustules need to be visible with the naked eye rather than the microscope, and to be non-infective. This diagnosis specifically excludes cases where the pustulation is restricted to psoriatic plaques, which would be considered psoriasis with pustules rather than pustular psoriasis. Again, recognizing the heterogeneity of the condition, three subclassifiers are applied. It can occur with systemic inflammation or without systemic inflammation. It may occur in patients who have psoriasis vulgaris elsewhere or independently, or those who don't. And again, some work suggests a different genetic architecture in these different circumstances. And thirdly, it can either be the relapsing type or the persistent type. The relapsing type should relapse more than once for this diagnosis, and the persistent type needs to persist for greater than 3 months. And obviously this poses a difficulty in diagnosing the disease when it first presents and hasn't yet had the time to either relapse or persist. And under these circumstances, it could be considered a working diagnosis. And so to return to my two personal cases, the first of acute GPP Zumbusch. This patient had elevated CRP and a high neutrophil count, didn't have plaque psoriasis, and according to the ERASPEN diagnostic classification, she would have generalized pustular psoriasis with systemic inflammation without psoriasis vulgaris of the relapsing type. Whereas the subacute annular GPP that I presented would be classified as generalized pustular psoriasis without systemic inflammation with psoriasis, without psoriasis vulgaris and of the persistent type. Subsequently, the Japanese Dermatological Association has produced diagnostic criteria for GPP. They have recognized 4 primary parameters to make the diagnosis, and these are first, systemic symptoms, which include fever. Secondly, an exanthem with multiple sterile pustules that sometimes merge to form lakes of pus. Thirdly, histopathological features, in particular subcorneal pustules and spongiform pustules of Kogge. And fourthly, the natural history of the condition is towards repeated recurrence of these features. When only the second and third of these parameters are present, the diagnosis of GPP would be suspected rather than confirmed. Several exclusion criteria are applied, and as with Eraspen, they exclude psoriasis vulgaris with transient pustule formation and also exclude AGEP, whereas in contrast to Eraspen, the annular form is also excluded, as for instance is subcorneal pustular dermatosis. And so when we consider the variants of generalized pustular psoriasis and other possibly related entities, you can see that these 2 classification criteria differ in how they handle subacute annular GPP and Sneddon-Wilkinson disease, and also other rarer entities such as recurrent circinate erythematous psoriasis, pointing to the need for international consensus as to how these conditions are diagnosed. The accurate and reliable assessment of the severity of GPP is essential, both for providing effective patient care and also for the development of new treatments. Until recently, disease measures used in plaque psoriasis were applied, but this is not ideal because of the unique pathology and clinical features of GPP and the acute and potentially life-threatening nature of the flares. More recently, disease severity measures have been developed specifically for GPP, and of the clinician-reported outcomes, I will describe the JDA severity score, the Generalized Pustular Psoriasis Physician Global Assessment, and the Generalized Pustular Psoriasis Area and Severity Index. Of the patient-reported outcomes, the psoriasis symptom scale has been validated for GPP, and pain VAS, the functional assessment of chronic illness therapy, FACIT fatigue scale, and quality of life scores such as the DLQI have been used. The JDA severity score divides this disease or categorizes the disease into severe, moderate, and mild based on assessment of 2 separate domains. Firstly, or A, evaluation of skin signs, and secondly, B, the evaluation of systemic features and laboratory findings. For the skin symptoms, the area of erythema, the area of erythema with pustules, and the area of edema are each scored on a scale from 0 to 3 to give a total score of 9. In terms of systemic features, fever, elevated white cell count, elevated CRP, or reduced albumin are scored from 0 to 2 to give a total score of 8. And these are then summed, giving a total JDA severity score from 0 to 17. And severe disease is categorized as a total score of 11 to 17, moderate from 7 to 10, mild from 0 to 6. This score has the advantage and also the disadvantage of combining both skin features and systemic features. The Generalized Pustular Psoriasis Physician Global Assessment, or GPPGA, is clearly derived from the PGA widely used in psoriasis, with the substitution of a pustulation score for the normal induration score. Each of these three domains is scored from 0 to 4 and then averaged. The pustulation score relies on the density of the pustulation, from 0 if there are no pustules through to 4 where the density is such that the pustules are actually merging to form lakes of pus. Sometimes this pustulation subscore is used in isolation of the total score for clinical trials. The summed average of these scores is then translated into a descriptor for clear, almost clear, mild, moderate and severe. This score has the advantage of being further validated subsequently, but the disadvantage that it doesn't record the area affected or systemic features. And then the GP-PASI is highly analogous to the PASI, and similar to the GPPGA. The induration component has been replaced by a pustulation component, but otherwise it's the same, and so the score is from 0 to 72. This scale currently hasn't been as validated as the GPPGA and has some of its disadvantages in not recording systemic features, but does reflect the area affected. And so, in conclusion, the rarity of GPP and its clinical heterogeneity poses a challenge for clinicians in establishing a precise and accurate diagnosis. The diagnosis rests upon a careful assessment of all the clinical features, often supported by laboratory investigations and sometimes including histopathology and genetics. I've mentioned the differential diagnoses, including HEP, psoriasis with pustules, and so forth. I've described the diagnostic criteria that have been developed by Raspen and the JDA, and mentioned that international consensus is needed to try to reconcile the view for entities that don't fit these criteria. The various severity scores that I've mentioned, including the JDA, GPPGA and GP-PASI, all require further validation. Thank you very much.